we have now the pleasure of inviting Dr. Chang. As you all know, he's one of the most influential ophthalmology, I think ranked 5th most influential in the world. He has several books to his credit. He practices in the LA area and a great friend of India, but everyone loves his videos and his teaching, specifically in cataract surgery. So over to you, sir, with your talk on Phaco with zonulopathy, your 6 best pearls. Thank you.
Well, thank you so much. It's certainly an honor to be here and to share the stage with this all-star faculty from India. No financial interest in any device. I'm going to give you my 6 best pearls for diffuse zonulopathy. Enlarge the CCC diameter, go to capsule retractors early, take advantage of this spiral CTR injector, use a dispersive to put the posterior capsule on stretch, think about a 3-piece IOL sulcus with optic capture, and don't be late to convert to a manual extra cap. So let's illustrate this. You know, it's not enough just to get the lens in the bag. We have to prevent this complication of late bag IOL dislocation, and we have to think about that. Zonulopathy often forces us to make a smaller rhexis just to complete it, but the key is don't leave it there. You can make an oblique cut and then re-tear it, sort of a secondarily enlarge it. When you see capsulophimosis, it's always when there's diffuse zonulopathy. And what that tells you is that that rhexis kind of acts like a sphincter. It wants to constrict. And what stops it from constricting this much, in every case, is the centrifugal tension of the zonules that are resisting that. And that's why making that rhexis larger when you have pseudoexfoliation will really help to prevent that. Now, if you're not comfortable with that, you can make little relaxing cuts in the edge of the rhexis. Just think of it like a capsular sphincter, and you won't be leaving it too small. In this particular case, I'm actually tearing it out to the edge of the optic. You don't have to go that far, but the larger you make it, the less it will want to contract. And of course, you get into this vicious cycle where it contracts more, and then that tugs more on the zonules, it contracts more, and that's how you end up with this serious capsulophimosis. Now, pearl number 2, these are capsule retractors, and they are going to be artificial zonules. They're going to give you counterfixation to the bag in a way that a CTR will not. So when I know from the rhexis that I've got diffuse zonulopathy, I'll put this in before I even rotate the nucleus, because when you rotate the nucleus, you need counterfixation of the capsular bag to prevent that action from tearing more zonules. These are from Microsurgical Technologies. It's the CHANG version. I have no financial interest. And be careful not to tighten them. This is not like iris retractors where you want to put this on stretch. And remember that with the infusion, everything moves back a little bit, so sometimes these can be too tight. But you can see how this also keeps the peripheral capsular bag from being aspirated into the phaco tip. It restrains that, and it supports it in the AP direction while giving that counterfixation, letting me rotate the nucleus. So you want to delay putting in a CTR and use these to fixate the bag during the phaco. All right. Now, look at me trying to put in the CTR. I know it's going to decenter the bag, and this is, look at the zonular dialysis. There's no zonules down and to the left. My goodness, I cannot get this in. If I persist, I'll dislocate the whole thing, and I have to come out. This is a dead bag syndrome. So this is a great innovation from Dr. Shimawaki of Japan. The one hook retracts the one eyelet, and the fixed little hook bends the lead eyelet. So now when I go in, instead of having the capsular bag and the zonules being what bends the CTR, it bends automatically. And all that tension in the CTR is borne by that fixed hook rather than by the capsular bag. And then you just tilt it a little bit and it will drop in there. You can see it's available through Corza and Katina. Great invention by Dr. Shimawaki. When you have capsule retractors, this can be hard because the eyelet can get tangled in the retractors. The bag may be lax in those areas. So you can see here how this nicely allows this to unfold and basically avoids trauma, further trauma to the zonules from the actual insertion. Sometimes it doesn't fall off. I'll use a second instrument to knock that off. Now, look at the posterior capsule. I know it's a zonulopathy. I'm trying to guard with my chopper, and I move it just right there. And you see I aspirated that. Why did that come up so quickly? And there, you can kind of see in the middle, I have a puncture in there. So what I should have done is stopped around this point and filled the bag with dispersive. What's going on? Normally, zonules keep the posterior capsule taut. But if the zonules are weak, there's a lot of laxity in the posterior capsule. So it flies up to the phaco tip when you're not expecting it on your low epinuclear setting. So instead of proceeding, when you fill the bag with a dispersive OVD that resists aspiration, it puts the posterior capsule back on stretch. Here's another case where I'm doing the same thing. So it's not just that you're moving the posterior capsule back, you're stretching the bag in the absence of the centrifugal pull of the zonules. And so here you can see how there's some viscoelastic to your left still. That's because it's a dispersive and it stays there. Now, I have the same problem. The posterior capsule is not anchored. It's not taut. So it doesn't want to separate easily from the cortex. I have to be so careful that I don't tear or aspirate the posterior capsule. And yet I don't want to put a CTR in now because that's going to trap things. So I pause and I put in a dispersive, again, to resist aspiration. And it's putting that posterior capsule on stretch, like as though the zonules were strong again. And now see how that cortex separates easily. Biaxial INA is a great choice here. And then if you don't use the spiral injector, see how I aim the CTR injector tip to the left so that it opens to the right and doesn't displace the bag. Now here's a case where I did all of these things, and after putting a CTR in and a three-piece in the bag, I've got terrible pseudophacodenesis. So now what am I going to do? Well, I can't leave it that way. So maybe I can put it in the sulcus. Maybe I'll need to suture the haptics to the iris. Well, I enlarged the rexus, as I showed you earlier. So getting this from the bag into the sulcus, not so easy. This is an older case, but it's one that taught me a lot. So I have to bring the lens into the anterior chamber. And then one haptic at a time, because of the posterior angulation of this lens, I can get each haptic under the iris, but in front of the anterior capsular rim. And here you see the fact that I'm able to rotate and displace the lens so much shows it's in the sulcus. Okay, so now here's the question. What happens? I shake the eye and it goes from jiggling to being absolutely still. So this was the index case that taught me this, because this is the same lens in the exact same eye, but I'm comparing two locations, in the bag and in the sulcus. And the conclusion is you're getting extra haptic ciliary body fixation, as though it was a ciliary body fixated lens, by not relying just on the zonules. Now here's a case with a zonular dialysis nasally. I've got my retractors then, and so I'm going to do the same thing. Now here I'm going to put this in the sulcus. I don't want it to rotate into the meridian where the zonular dialysis is, and I'm going to capture the optic. Before I do, I aspirate some of the viscoelastic behind the IOL, because remember, we're trapping the optic in the anterior capsule, and this prevents contraction of the rexus, it centers the lens, prevents rotation, and I don't have to adjust the IOL power. Finally, here, look at, this is a dense lens, and look at how much phacodenesis I have just to complete the rexus. And our younger colleagues who aren't experienced in extra cap really should learn how to do this, and we should do this more often. And that is what? I'm making a can opener, I'm moving superiorly, converting to a manual extra cap. If you're really confident in SICS, you can do that, but this is not the time to practice it or learn it when you have this kind of giant lens. And why do I say that? Well, this is going to be much better for the cornea, and certainly we can preserve the posterior capsule so we don't have retained lens, but also I'm not going to have to suture fixate the bag with some kind of sutured element, because this lens, it's a three-piece, you know, one of the haptics probably going to end up in the sulcus, and this will never dislocate. So I've got great fixation. The only thing is I have some sutures in an eye that was horrible preoperative vision to begin with. So this is an underutilized technique, in my opinion. So these are my 6 pearls. They're not things that we're all used to doing, and I hope this is helpful to you. Thank you very much.
Thank you very much.